Hello, good afternoon. If I could get a confirmation of sound. My name is Dr. Jyoti, and I'm here to introduce Dr. Marangu, who is going to discuss asthma in children. Dr. Marangu is a pulmonologist. She's also a pediatrician, and she's going to take us through various aspects of asthma. So we're going to go over the diagnosis, the treatment, and the follow-up. So welcome, Dr. Diana. We look forward to hearing from you.
Thank you very much, Dr. Tanya. I don't have video, but that's fine. So thank you for joining all of us this afternoon. I see we almost have 400 participants on the call, which is wonderful. And today we'll have a discussion on asthma in children. I really want this to be as interactive as possible, and there's no, let's learn from each other and as we go along, okay? For some reason, okay. So when it comes to, what's the magnitude of the burden of asthma, and it's actually the most common chronic disease of childhood, okay? Here in Kenya, when I'm explaining it to most of the parents, I try to put it in a perspective that they can understand. 1 in 5 children has asthma, and this prevalence is increasing. So the reason we're having this discussion is it's because asthma has wide-ranging implications, especially to the children's health. But these children are not just, alone. They come from families. So these families are also going to be troubled in one way or another, be it financially or from a health perspective or from quality of life aspects. And on the bigger scale, then the health system is burdened, because a lot of healthcare utilization goes to management of asthma. So in the US, the data are about almost 82 billion per year goes to the healthcare utilization attributed to asthma. What's most disturbing is that mortality from asthma still occurs in children. And this is very, very, very troubling, because we know that mortality from asthma is preventable. So what is asthma? There's so many definitions. I think this is one of the most classic definitions. Heterogeneous disease, just meaning there are different forms and flavors of this illness. It's not just one way of looking at it. So that's the heterogeneous aspect, and we'll talk a little bit more later. And the characteristic of this illness is chronic airway inflammation. The 2 defining features that are quite key are the history, of the respiratory symptoms. So children may wheeze, they may not. They may have more of coughing. They have shortness of breath. They may have chest tightness. And these symptoms vary over time and in intensity. So they may be coughing in the morning, at night, but during the day, they're perfectly fine. Okay, sometimes it's really bad, sometimes it's okay. So that's what I mean by that first point. The next key defining feature is the expiratory airflow obstruction is variable. And this is very important when we're discussing asthma. So we're going to simplify it as much as possible, but it's also important to understand that lots and lots of people do lots and lots of research on asthma, because it is also a complex disease, because it results from a combination of our genetic susceptibilities, our biology, how we are made, and this interplay is with the environmental exposures. It could be dust mite, it could be, the cold, it can be many various things, our exposures to pests like dogs and cats, it could be the cockroaches in the kitchen, lots of environmental exposures interplaying with how we are made, our genetic susceptibilities, our inherent biology. So I'll just keep emphasizing the hallmark of this disease is chronic airway inflammation. And there are lots of pathways. Simply put, maybe I really love this cartoon out of the New England Journal of Medicine in 2017. And it tries to simplify, the type 2 inflammation, and we have non-type 2 inflammation. And these different pathways, at the end of the day, what this results in, there's a lot of hyperresponsiveness in these airways, remodeling, mucus production, and there may be smooth muscle constriction and hypertrophy. But the hallmark of this disease is chronic airway inflammation. And so with exacerbation symptoms, the airway narrows, and that's what we, the smooth muscle in these airways constricts. And that's when children may present with the different exacerbations. They could be mild, moderate, severe, life-threatening, critical, as we'll talk about later. Most importantly is that asthma can be fatal. We may take this lightly and kill. And this is one of this slide I project here was quite, I think, disturbing for me when I looked at this. This is a post-mortem specimen. And if you look here, these are airways. You can see there's some airway as well, but this airway is plugged. There's plugging of these airways. And this was from a patient who had, of course, fatal asthma. So I think sometimes it's important to just understand the magnitude. What are the implications of this illness? Therefore, its importance. So then, how do we diagnose asthma in children? Okay. I think I tried to have some questions earlier on, but I think we go straight to this. So in children, the diagnosis of asthma is clinical. Okay. And this is the confidence I want to infer in you. This is a clinical diagnosis. So listen to these parents, listen to the caregivers who bring their children. The history will be of variable respiratory symptoms. There are some typical symptoms, as I mentioned, wheeze, shortness of breath, the chest tightness. They might have none of this, and they may just have that subtle cough. Okay, that can be very typical. They may have, more than one of the symptoms. They occur variably over time and vary in intensity, which I shared earlier on. The symptoms tend to occur or are worse at night or waking up. These tend to be the coldest times of the day. They are triggered by exercise, laughter. I'll talk about all manner of emotions. So it could be happiness and they're really laughing, but it could also be crying. For children, exercise is play. So when they run up and down and you see that they're coughing much more, they're a little bit short of breath. Think about this. It could be allergens. I talked about some of this, be dust mite, dog, cat, cockroach, molds like the aspergillus, the alternaria. It could be the cold air, as we've just discussed. These symptoms tend to worsen, or they may occur at the same time with viral infections. So that child, they've just begun school, they tend to have this repeated viral infections, but with them, then they present with wheezing, they come in, they're getting nebulized, think about asthma in such a child. So history is very key. Then you go ahead, as we know, as we are clinicians, we go for that physical exam. So just to summarize, the child with asthma is often normal. They'll present in your practice that time during the day, and they are fantastic. In fact, the mother is like, kohoa vile alikuwa na kohoa usiku, that means That's Swahili translated into English. In case we have our audience that may not understand Swahili, they may tell you, cough the way you tell, the child is not coughing the way they were coughing at night. Cough the way you are coughing, because they seem perfectly fine at the exam and the physical examination. So they're often normal. You may auscultate some wheeze, or if they've come in an exacerbation, then they may have more later. So this is an otherwise healthy child. Okay. They may also have other, I'll say maybe signs of allergy, of atopy, and we'll talk a little bit more about that. But remember, not all that wheezes is asthma. Wheezing can be found in other conditions. There are many others. So there could be other respiratory infections. It could be children with upper airway dysfunction. Remember, this is wheezing is really mainly in your small airways. Or it could be large airway, but there's blockage of an airway in such a way there's turbulence, and that's how you'll hear that sound. So this blockage could be inside the lumen of that airway. It could be within the wall of that lumen. It could be outside, extraluminal. And there are so many other reasons, including inhaled foreign bodies, tuberculosis, which are examples of this endobronchial obstruction. And children may wheeze because of all this. So identify what are those red flags that make it unlikely to be asthma. Remember, though, asthma can be a comorbidity. So again, the children who can come in a very severe asthma exacerbation and may have no wheeze whatsoever, what we call the silent chest, and this is ominous, okay? And it's also good to remember this. So wheeze is not the only sign you'll be looking for in asthma. Really, the signs we're looking for are just maybe what else could be additional and what else points towards something else, a different diagnosis. So as I talked about, there are lots of asthma masqueraders. It can be bronchiolitis, reflux. Reflux is notorious. We underestimate reflux in children, microaspiration. Children who may have been born preterm and have related lung disease may wheeze later on. They may be associated with asthma, but or not. I've talked about foreign bodies, which we really need to make sure we are not dealing with, and all these other, even congenital heart disease. I put it here because children will come in, they have fast breathing, what looks like pneumonia, and they're wheezing, but they're in heart failure. So examining these children in totality, listening to that history, going in for that clinical exam makes the whole difference. So examine for these red flags. Also know that this child who has asthma could also be refluxing. So comorbidities can exist. And it's not that you can only have one illness in the same child. So again, my emphasis here, the history. You go ahead, examine to look out for any red flags and identify any comorbidities. This is really the key. These two aspects. We may have additional tests for children who are above 5 years. Spirometry, which is a form of lung function, may help support this diagnosis and also help you maybe identify an alternative reason for why they may be presenting in this manner. And this is largely available in many of our settings, including Kenyatta National Hospital. So pre-bronchodilator, they have obstructive illness. And in this flow volume curve here, you can see this respiratory curve. This is inspiratory curve on the flow volume curve of the spirometry. And then after you give a bronchodilator, you actually see the obstruction improving. Again, this is during COVID-19 pandemics. Choose your patients wisely and follow your strict infection control procedures. There are other tests you can do quite easily that can help you monitor these patients. For example, like peak expiratory flow rate, quite simple, cheap, widely available. Just ensure that you have optimal technique. And I share a link on how to do this effectively. This is something you can do very easily in your office. We do also have additional tests that support diagnosis. For example, if you think this is more atopic, children may have a positive skin prick test. As you can see, this is a child from our practice. This was grass pollen, dust mite. You can see the wheels right there. And when they're palpated, anything 3 millimeters or more is positive. The cockroach, I think, was also positive. That's your negative, your control. And you can see here histamine reacted, that's a positive control. So you're able to identify children who may be sensitized. Yeah, as I mentioned earlier on, they may have other allergies like atopic dermatitis, allergic rhinitis. And it's really important when you have a skin prick test to see what they're sensitized to and what maybe could help in their management in terms of avoidance and control. Fractional exhalation of nitric oxide, the pheno, that's also available in some of our practices here in Nairobi. And especially to inflame, the pheno will be elevated. For children who, and this may be at the subspecialist practice level, sputum for eosinophils and neutrophils induced sputum may be taken and may be used for monitoring of treatment. So Gina has very nice algorithms on, how you're going to look at I think that came out of the European Respiratory Journal last year, also on possible algorithms in the diagnosis of asthma in children. But really, I'll just emphasize asthma in children is clinical, is a clinical diagnosis. The additional tests just support your diagnosis and they may be useful in the follow-up. Okay, I will not overemphasize, and a reminder, chronic airway inflammation is the hallmark of this disease. So then it follows that when we are managing this disease, a controller is useful, is very important. It's going to be the mainstay of your treatment because this is going to stop inflammation. And this is where inhaled corticosteroids come in. And of course, in times of exacerbations, when there's smooth muscle constriction, then a reliever is needed to relax that smooth muscle. And you can use the short-acting beta agonists, like your salbutamol, that will give relief quite soon, quickly. So I think I'm just really emphasizing many of the points I'm saying. These are the most crucial aspects when we manage asthma in children. So I talked about this GINA guidelines, and you'll look at I'll share the links on this slide. And there are different ways they've portrayed this. I've talked about really our diagnosis, and you'll see from the previous guidelines that were before 2017, there was a time when short-acting beta agonists were being used in step 1. But that because of the mortality that was arising from children only on SABAs, this had to be revised. And really, you start with controllers from the very beginning. And I'll just maybe just highlight that, you can look at it at, step 1, step 2, step 3, step 4, step 5. And it just helps you know, based on symptoms, are the symptoms less than twice a month? Are they twice a month or more, but less on a daily basis? That's step 2. Symptoms are most days or waking with asthma once a week or more, then you're at step 3. Symptoms are most days or waking with asthma once a week or more, and your lung function testing is quite low, you'll probably be at step 4. And for those children who are uncontrolled, that's step 5. And it just guides us on what are the options for optimizing your treatment. But most of the time we'll start around an inhaled So SABA only treatments, so that's a using of like Ventolin only, it will increase the risk of severe exacerbations. It has been found to be associated with mortality. And that's why when we add an inhaled corticosteroid, it significantly reduces this risk. And that's why we must use an inhaled corticosteroid in management. So, and you may step up or step down, and we'll discuss this in terms of follow-up on different approaches you could use. Again, just share this so that you can just know that in terms of the GINA guidelines, they share about children who are about 6 to 11 years. They have guidance on children who are, adolescents, so 12 and above, and they do have guidance also on children below 6 years. So I'm emphasizing, and this is from a safety aspect, those were the landmark changes in asthma management. We do not recommend SABA only treatment at all. For adults and adolescents, it's really about symptoms, and that the regular low dose ICS controller is key. Okay. And there are different approaches, and again, you'll see low dose ICS with as needed SABA. That's still something that we can use, and I use in my practice. And this is really important. Just know, if you remember that the hallmark is chronic airway inflammation, then there is no doubt in our minds why we must use the inhaled corticosteroids. And there are also schools of thought that talk about as needed low dose. And I see an inhaled corticosteroid with a LABA, okay, when needed. Again, a lot of data emerging on this approach. And we'll talk about most of this. I think this is just a very nice summary slide. Maybe for step 1, you do your low dose ICS, and then whenever a SABA is taken, or you just have a daily low dose inhaled corticosteroid. And then starting, if you're on step 2, starting on a daily low dose inhaled corticosteroid, you could add a LABA in step 3. You could be on medium dose ICS and a LABA as well. But beyond this, really, these children should be at, from step 4 onwards, these children should be with a pulmonologist. So I think most of this talk I've just been talking about control, because it's key. It prevents death, it prevents exacerbations, it prevents healthcare utilization. It'll actually also prevent impaired growth. So lots of parents will come in and they'll be like, oh, why my child is on this budesonide or this fluticasone inhaled corticosteroid. It's a steroid, and I know it's not safe, but actually inhaled corticosteroids are very safe. There are lots of, there's a lot of evidence out there. Maybe 0.5 to 1 centimeter loss in height in terms of the whole maybe lifetime of a child who is on follow-up for asthma. So this, when compared to the benefits, is really negligible. So this is a nice systematic review by Zhang. And the whole idea as we go on with our treatment, you want to use the lowest dose of the inhaled corticosteroid that achieves the control. And you can add on a LABA or a leukotriene receptor antagonist rather than increasing the ICS dose. So quite a while ago, there used to be a lot of controversies about using a combination of an inhaled corticosteroid and a LABA. Like, for example, LABAs are like formoterol, salmeterol. But that is no longer controversy. It's very safe to use in children. So we've talked about inhaled corticosteroids being the mainstay of treatment. They are safe, and the inhaled medications are best because they're getting directly into the lungs where they act. And also when you're using them in an inhaled fashion, as we've discussed, you have minimal side effects, very, very safe. Remember, when you're having to manage exacerbations with systemic steroids like your prednisone or hydrocortisone, you're giving doses in milligrams vis-a-vis giving doses in micrograms. And you can see that is 100-fold difference right there. So in terms of safety, then we can see the advantage. And we give inhaled medications through devices, which are called spacers. Spacers can be valved or not valved. Ideally, your best practice and best effect is to have a valved spacer. I'll show some pictures of those. But anyway, when we are using metered dose inhalers, we've seen the Ventolins, the Budecots, and so on and so forth. They must be used with a spacer. They improve the delivery of that medication. They reduce how much of that medicine is deposited at the back of the mouth. And of course, it will overcome the challenges of coordination in terms of breath holding. And for those children, you can have who are much younger than 3 years, you can use a mask as well, and you overcome that challenge. So it makes it so much easier to deliver this medication. And there are different ways we can use, but spacer use is in all children. I would also beg to say it's actually even in adults for better drug delivery. You can see this picture of this mom using a bottle. This is like a soda bottle or a juice bottle or a water bottle that has been improvised. We see the metered dose inhaler right there. And here is a face mask, and it's covering the nose and the mouth. And the mom is actually able to give the medication. This is an unvalved spacer, but nonetheless very affordable and reachable and useful for children. So for older children, and I talk about for older children, again, this will be based on your practice. And it's for children, not just about age is not the only factor. Remember, you want to understand, can this child coordinate? They don't have any neurodevelopmental aspects, anything that may prevent their coordination. So if they can drink out of a bottle without it dripping out of the sides of their mouth, then they can use a spacer with a mouthpiece. That's my practical advice. And you will see what is going to work for you. So these are just this young man here, this young boy is using his spacer with a mouthpiece. Okay. So valved spacers, this is what's optimal. Just helps trap that medication in, and it's only when the child breathes in that the medication is delivered into the lungs, into the airways. So again, Gina provides guidance on what are the ages that are what preferred devices are there for different ages. And you see there, it's no surprise, under 3 with a face mask. Above this age, they can be with a mouthpiece. But just remember, it has to be children as long as they can coordinate. Huh? So my advice is there are many techniques, but in children, tidal breathing, which is also known as a multiple breath technique, where they're just breathing in and out normally. That's the easiest technique to use. There are other techniques you can use like breath holding, but really what we teach most is tidal breathing because it's really easy to do and you get that medication right into the lower airways. And some suggestions that I could give for your different practices is create a video, where you do it and just go with the steps, And I'll take you through what some of the steps are. But you can create a video so that your patients know how to do this, and you can share it with them either the first time, you could do a live demo. You could share it with them as well so that they can go home and, if in case they forgot something, they can practice. And there are also videos available in the public domain on the correct technique that you're teaching. At least 10 breaths per every actuation. That should be enough to empty what's in the spacer and for that drug to get delivered into the lower airways. So again, assemble that spacer, take the metered dose inhaler, remove the dust cap, that's the cap that is there. I say look into in the MDI. There have been cases where cockroaches have hidden in there, and you're inhaling cockroach every time, and you're wondering why you're not getting better, or the child is not getting better. So look in, then shake it, fit it into the spacer. If you're using with a face mask, ensure that it covers the nose and mouth well. If it's with a mouthpiece, let it get in the right way. Once you press the inhaler and it actuates, based on what your prescription was about how many micrograms are going in of either that budesonide or the fluticasone, then let the child take in at least 10 normal breaths. That's what we call tidal breathing in and out with each puff. And if you have a valve spacer, watch that valve moving with each breath. That helps you know that the medication is going in, or watch for chest rise. Then you know that breath is going in. So there's no time element here. It's really watching that the breaths have gone in, they're breathing. And then with every actuation before each, you make sure you get it out, the inhaler out of the spacer, shake it with every spray. Okay, and it's one puff at a time. It's not puff, 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 puff. If it was 4 puffs, it would be 1 puff, then 10 breaths. If you need to remove it, shake it again like that. And children can then clean their mouths after the medication. So depending on the routine, they do that and then brush their teeth. Okay, caring for the spacers. I think the basics: wash in lukewarm soapy water, leave to drip dry. You're avoiding wiping inside because of static. The metered dose inhalers, now they have dose counters, at least most of them. But those without dose counters, then you may need to keep count of your actuations so that you're not just giving the propellant. Yeah, so you really need to know how many doses are in each of the pressure metered dose inhalers that you're prescribing. So again, guidance from Gina, choosing, checking, correcting, confirming techniques are working. Do this. Have someone maybe in your practice that can help you do that to make it efficient, depending on the busyness of the clinics or the services you're running. So also have a way to measure or to objectively assess if a child is controlled. There are lots of tools out there in the public domain. Develop your own tool, customize your own tool that will help assess the children you're managing in terms of control. This is just an example of one that I use, but there are so many out there. Action planning. Make sure you discuss this with your patients as you follow them up. When they should be worried, what's a green zone, what's an orange zone, what's the red zone. I put this here because this is one of the areas I notice people ask lots of questions. How will you step down controller treatment? And how I answer this question, there is no only one best way of doing something. There are lots of ways of cooking chapatis. Some people like thin chapatis, fat chapatis, drier, so oilier. So it's different. But the most important thing is really about understanding principles. If you know that the hallmark of this disease is chronic airway inflammation, then then we've discussed that a controller is important. So at the end of the day, the aim in your management, in your treatment, is to get to the lowest dose that controls symptoms. That's the aim of your treatment. It'll control symptoms, they don't have exacerbation, and it will minimize the risk of the side effects. So when you may want to consider stepping down is when a child has been well controlled, and at least give it 3 or more months. And it shouldn't be at a time there's a respiratory infection or when they're traveling, when things are pretty stable. If you're doing lung function, their lung function has been stable for a while. So don't rush to step down. Parents will try to get off inhaled corticosteroids because they think it's addictive, they're going to be dependent. There are all manner of reasons that they want to get out of the medication. But it involves a lot of communication as their healthcare provider to just allay these concerns. And from the very beginning, talk about this. This is asthma, it's about control, and it's really going to depend on your child, how we are able to control them. And it may take as long as it's needed. That's the bottom line. So there is no way of saying for this child, by 2 years, this is going to be over, or by 5 years. Those are lies. And when you should manage the expectations very early on, and it will help you collaborate in the care of your patients and in the care of these children. So when you're choosing when to stop down, make sure that they've been well controlled for a good amount of time. And they're not at a point where they are having some exacerbations, or they're not stable even in their lives for whatever reason, they're traveling and all. Okay. So for that reason, then control has to be quite objective. You've written down your asthma action plan. You're seeing them on, a regular basis, be it 1 monthly, 2 monthly, 3 monthly. Again, this will really be about flavor of your practice and what you do. But just remember what are the principles, and then this will come with your expertise and time on how to do this. And there are so many ways, if you read in the literature, of how you're going to do this. Will you step it down at about, try to get a quarter down, 25% at 3-month intervals, or 50% at 3-month intervals? See that. I mean, this is what's been documented in the literature, but you just do not just stop an ICS. This is not recommended. This is going to put your children in a time that maybe may look just nice and quiet for a bit, and then they come back worse. So I think this is usually the missing link in most of our management. Now I'll just really try and just touch on a few other areas. We have basic pediatric protocols in our country. These are for children up to the age of 5 years. I know we use them a lot in the public facilities and even private facilities within quite nationally in our practices. And they talk about how we can manage asthma. And this may be, I look at this at the point of exacerbations. And this is one guidance that we have. When I think of acute exacerbations in asthma, classify the severity. Is this mild to moderate? Is this severe? Is this life-threatening? And there are different ways you could classify this. I just show you one way that we can. And you look at the consciousness level. How is this child? Are they able to talk or vocalize? Remember, you have to know the developmental aspect of these children. How are they? What is their work of breathing? Are they using accessory muscles? What are their saturations in air? Pulse oximetry is key. The respiratory rate, count that in that full minute, assess that, and make sure you're assessing in terms of, is this, age-specific tachypnea? Are they wheezing? Don't forget about that silent chest in that child who is coming in an acute exacerbation. That can be ominous, and that you can see is on the life-threatening panel here. What's their heart rate? Are there any other signs? Are they hypotensive? And this will help you classify, is this mild to moderate? Is this severe? Is this life life-threatening. So exacerbations is where you actually are classifying, mild, moderate, severe, life-threatening. Okay. So these are all children who have asthma. But I think what I want to emphasize for the purpose of this presentation is your management, that golden hour in which they present to your acute room, or in the casualty or accident and emergency room. That golden hour is very key. Manage them optimally. Start the salbutamol, ipratropium, nebulize them every 20 minutes, have those 3 back-to-back nebs, give oxygen if needed, start your systemic steroid as appropriate, and keep reassessing them. And as you reassess them, then you'll change the setting. Is this a child who can then go home? Is this a child who needs to be hospitalized and monitored for a bit? Is this a child who needs to be in the HDU and you go on with further management, for example, intravenous magnesium sulfate? They may need to go on non-invasive ventilation like BiPAP, which is really, really, really good, or high flow oxygen. They may be on much more regular reliever nebulizations, could be even hourly. That systemic steroid should have been started within that golden hour, as we talked about, and they may need to be on regular steroids for a bit. So this is really just an overview of what acute exacerbations could look like and how you may consider their management. So that child who's in ICU may need aminophylline, they may need IV salbutamol, they may even need to get into invasive ventilation, which is really, really difficult in children who have asthma. What we want to do at the end of this, I think this talk, I hope you understand, is you want to prevent these children from getting into these acute exacerbations. And if you really control them well and follow them up well, then you hardly get into these situations. So that's the message I'm trying to point out here. And we know that it can be life-threatening. And we saw earlier on in that post-mortem histology picture of what fatal asthma could look like. So again, from Gina, these are the aspects that will predispose a child to have a future exacerbation or have some airflow limitation. So if you don't prescribe that inhaled corticosteroid, if that technique is poor for the inhaler technique, they're not adhering to treatment, they're having to use lots of their short-acting beta agonists. They may have comorbidities. Their exposures are not being controlled. On their testing, you're seeing they're just, the eosinophils are still remaining high. The FeNO is high. The lung function is not optimal. And even that child who's had one or more severe exacerbation in the last 12 months, in the last 1 year, that child is at risk for a future exacerbation. And these are the children, these are the things we want to mitigate quite early to prevent morbidity and mortality. So then, as we've seen, in most of our practices, we can manage these children with asthma well. We've said it's a clinical diagnosis. We know how to control them and follow them up. But there are those children, and I mentioned earlier on, whose disease is quite severe. And despite the treatment you're giving, it's not optimal. They're still getting exacerbations. These children should be referred to a subspecialist as early as possible. So timely referral is important. And maybe these are just some of how I would summarize which child is this you want to refer to a pediatric pulmonologist. So this is any child who's been hospitalized with an asthma exacerbation in the last 12 months. So in this 1 year, if they had an exacerbation and they've been hospitalized, it was severe enough to be hospitalized, that's a child who you should refer to the pediatric pulmonologist because something is not working, okay? If they're on step 4 medication and above, that's a child who should be in the hands of a pediatric pulmonologist. Those red flags I pointed out, those masqueraders and comorbidities, they are failing to thrive. That child is wasted, they're not gaining weight. That's not asthma, that's something else. they're not responding to your treatment, it could be asthma, but it could be asthma plus, comorbidities. There's something that we are missing. So refer them in a timely manner. And of course, if you're not sure of the diagnosis and you're managing this child, we're here for you. Consult us and we will guide you. So I just put this here because this is a child a month ago, came in wheezing, I think, had been actually the main issue here, they'd been coughing persistently. And this child, about maybe 1.5 years, going to 2 years, being managed as asthma. But one of the clever actually now consultants looked at this radiograph and was like, something's not right here. It looks like that left side of the lung looks darker than this side. I'm not sure what it is, doc, but I think see this child. And sure enough, I think I've shown this before. This child on examination, before actually I go to this, this child had actually reduced air entry on that left side, soft breath sounds, but on the right, much better. And clinically very worried that this could be some luminal obstruction with some form of ball valve phenomenon on the left main bronchus. And these were these airways. There was a chronic foreign body. That's granulation tissue you're seeing there. And maybe I'll just try and play it from a little bit down. And this is on flexible bronchoscopy when we did this. That was the foreign body right there. So it was a peanut that, as we kept removing it, was coming out piecemeal and kept moving from one bronchus to another. But successfully, we did manage to get it out piecemeal, and that with as a team effort, and we saved this child's lungs. So with that, I've tried to keep it at 50 minutes for this presentation. That's the end of the presentation, and I see we had 1,000 participants. That's wonderful. I welcome I give the floor back to Dr. Tanya for any questions and discussions. Thank you very much.
Thank you so much, Dr. Marangu. That was an interesting presentation, quite concise, and I really appreciate the emphasis on the important thing. I'd like to actually let you know that the reason that I'm an asthmatic and after a similar presentation is when I got on the long-term medication, and it's actually helped, so it does work. Now we have quite a number of questions in the Q&A, and I think perhaps I'll just read them out because some might be repeated. Then we can just tackle them one at a time. So one of the most common questions that we have is regarding the age at which we would diagnose asthma. One participant says that regarding the diagnosis of asthma, from what age can one diagnose asthma? Can it be diagnosed in infants, i.e. those under the age of 1 year? Thank you.
So we take them as they come, right? That's okay, age. Eh? So thank you, very good question. So it's how I like to answer this, because it's asked a lot, is that child who is an infant, the one who's below 1, there are many other reasons that this could not be asthma. So by the time you're saying this is asthma, have it as a diagnosis of exclusion, in the sense that, have you checked how are they feeding? Do they have reflux? Reflux is notorious in these children. Yeah, most likely bronchiolitis, a respiratory viral infection that's happening there. Depending on your practices and what's available, some areas you have, you maybe readily have respiratory biofires on, and you can see this is RSV or this is adenovirus, so on and so forth. Yeah. The history, they came in viral, runny nose or something like that. They were coughing, and that's a bronchiolitis. or of course, we know that there are other chronic lung diseases that could present like this. But in that under 1 year old, I'd want you to explore those masqueraders I talked about a little bit more before you attribute this to asthma. So that would be my guidance for you. The
Okay.
older child, very easy, much easier. 1 year, 2 year old, they've come in. It could be their first time. It doesn't mean that asthma, you have to diagnose it after several, it just makes it easier if they've come in, they've been nebulized before, you come in again, and it kind of makes it much easier. But you could be seeing it for them for the first time, and it's really, they've come in an acute exacerbation. They can even have landed into the ICU, and it's still asthma. So for age, maybe to answer simply, I think really look at your other differential diagnosis first, or those masqueraders I've talked about that could present this way, before you actually call that asthma. Thank you.
Okay, thank you so much. The next question, still regarding age, is when do we have, what's the youngest or earliest age to use an inhaler? The participant goes on to mention that there are infants, say 2 to 3, whom you nebulize with hypertonic with no total resolution of the wheeze. Can you allow them home on an inhaler?
So we're not discussing asthma. I think that sounds like bronchiolitis, isn't it?
Okay.
That sounds to me like
Yes.
that sounds like an infant with bronchiolitis, and you've tried salbutamol. If you found there was relief, you may go ahead and do that if they have no danger signs. Remember, bronchiolitis, again, it's a small airway disease. There's edema in these airways, plugging, and some children do respond to a short-acting beta agonist. Yeah, so those who need to be hospitalized may benefit from that hypertonic saline together with the salbutamol. Those who respond to the salbutamol, then it's worth giving severally if it does give the relief. And if it's a child who doesn't have danger signs and there's relief in that, I think I wouldn't hesitate, but follow them up. The thing about starting it and maybe saying this is asthma and then you haven't followed them up, or is where I think we miss the boat. But that to me sounds more like a bronchiolitis. Yeah.
Okay. So we have a question, a couple of questions regarding leukotriene inhibitors. So one participant asks, is there any role of leukotriene receptor antagonists in the pediatric population? And another question, just so that you can take them together since they're related, is what's your take on the leukotriene inhibitors, especially with regards to its side effect of nightmares and also its management in rhinitis?
Great question. And this is really, I know where this is coming from, the black box warning from the FDA, an example being like montelukast. So how I put it again, so a combination of something like montelukast together with a nasal steroid, for example, in allergic rhinitis, like fluticasone, is excellent management for allergic rhinitis. Also, medical management in children who may have comorbid adenoid hypertrophy. That's a very, I mean, there's really good evidence about that. So, and experientially it does work. But monitor these children. So this is not a child you start and then you're going to, not, follow them up. So early on, discuss with the parents. Say, some children may wake up with the nightmares. They may be more hyperactive than the usual. And some parents will just tell you, no, I not have this medication, or okay, let's give it a chance. And when you're following them up, then they do have, they don't have those symptoms. So it's not every child who exhibits those side effects. So again, it's about following up your patients and monitoring for these adverse events, and then stopping it when needed. So maybe I'm more of a proponent of actually watching for it and advising early. But there are people who will just not give it at all. So this black box warning, I think from the FDA, I remember everything is about guidance and just understanding well and know who you're managing. Is this a patient who will be able to come to me in the next 2 weeks? You know, I'll be able to follow them up. I think that's what's going to make your practice important and for the benefit of the children who you're following up. Yeah, thanks.
Excellent. Thank you. We have a few questions on nomenclature regarding how to label various aspects. So I'll just summarize them together. One participant says that most pediatricians would rather diagnose bronchospasms rather than saying asthma. What's your take on this? And another asks, what's the difference between asthma and bronchitis in children?
Excellent questions. Let me see how to answer this. So nomenclature and bronchospasm. So this comes from stigma. Dr. Justice Simba, I think, has some publications out there on, you know, how rampant stigma is in our context when it comes to asthma. But I think it can, by labeling bronchospasms, this is my opinion and experience, what it does, then you've denied the patient knowledge on what their diagnosis is, and therefore affecting how you're going to manage the child. So you may be labeling it knowingly that this is asthma, but I'll call it bronchospasm, maybe to avoid the stigma issues, or it may be really you're just explaining bronchospasms. I think you're just saying this child is wheezing, basically, in other words. So you're just saying wheezing because maybe you don't understand why they're wheezing. So I think if you're convinced this is the diagnosis, this is asthma, then treat it as asthma. As you follow them up, you will know whether this is asthma or not asthma, because either you're not responding to your treatment as you should expect. Therefore, think what else could this be? Comorbidities, should I refer this patient? I'm not making headway. So that's maybe how I'm looking at that question in terms of nomenclature about bronchospasm. Now, on the aspect of bronchitis, I think it's good to just be very clear what you're talking about. So this is a person maybe, so again, it may be the issue of stigma that the term bronchitis is being used, or are you applying, I know we had this on the grand round, maybe some of our participants here might not have had that discussion on PBB, persistent bacterial bronchitis. And that's an entity, a different entity. This child has been coughing for 4 weeks or more in an otherwise healthy child and is not meeting these aspects of asthma that we've discussed. This is not disease that is variable in intensity and all that. So you can't, this is not asthma, but you're thinking, but this child has this cough that is persistent and they're otherwise healthy, their chest X-ray is normal. And that child then is a different entity and we manage with antibiotics for 2 to 4 weeks. And that's a different entity. So if you look at the definition of PDB, that's different. That does not involve asthma. So, and it's good to say what you're dealing with and then you treat. So if that child you are treating and they're actually not responding, and then you start them on an inhaled corticosteroid and they actually start improving, then you're like, oh, actually that's not bronchitis, this is asthma. So I think it's important to, as you said, give it a name based on what you're doing and you treat as appropriate. But the key here is you must follow up. Because when you follow up, then you will know what you're dealing with. Thanks.
Excellent. So I think there's another question. Let's move to the realm of questions regarding diets. Given that we have a participant asking us, in inflammation being a hallmark of the disease, is there a place for anti-inflammatory diets?
So I'm not very sure about, I'm not clear about what you mean by anti-inflammatory diet, but maybe let me go back and say inflammation is happening locally in the airways. There's chronic inflammation in the airways. So that's a lot of mucus and all this. We looked at that pathway of all those different things that are happening in there. And that's why the treatment then, the hallmark of the treatment is something that is anti-inflammatory locally in the inhaled corticosteroids. And then you have also the modifying effects of, as you said, could be a leukotriene inhibitor, it could be plus an inhaled corticosteroid plus a LABA and all that. For the different pathways, it could be very severe disease, and you're actually looking at your IgE, like omalizumab and others. Yeah? So in terms of diet, even when you look at your GINA guidelines and most of the literature that comes out, diet as an anti-inflammatory diet, I haven't seen evidence for that.
All right.
I know people have been talking about maybe like triggers, where you're now talking about food allergens, but remember food allergy can also be comorbid with asthma, but most of the allergens tend to be aero allergens in asthma. Yeah, so again, and then remember the pathways. There are some the pathways that we talked about in terms of asthma that are not targeting the eosinophil and maybe neutrophilic, and that's a different entity. So maybe in short, for the diet, I do not know of presently of any evidence for an anti-inflammatory diet.
Okay. So we have a few questions on treatment, and I'll start with one of the ones that's usually very controversial. What is your take on oral Ventolin syrup or cough syrups with salbutamol in children with asthma? No?
Sorry, I'm right here.
Oh.
Sorry, I don't know what happened to my screen. I think I touched it. Oh, you know my take. But anyway, for the purposes
yes, I do.
of
everybody.
the participants, yeah, I mean, first of all, cough syrups, they have no role in asthma. I'm going to talk about it that way. We know that cough syrups are actually harmful in many indications. And there are very few times when your pulmonologist may use it. And it is definitely not in the case of asthma, in hemoptysis and so on and so forth. And that is when you're looking for an antitussive effect. But there's really no role for a cough syrup. It can be harmful. And then why would we want to use oral Ventolin? So think about that. You want to take a medicine through the mouth so that it can get into the bloodstream, so that eventually goes into the airways. Whereas you could actually inhale this medication, it's short acting and it relieves as soon as possible. So I think that's where I would, how I would explain that to someone. And really, I think it's more harmful. Now, your adverse effects of taking that oral Ventolin in terms of the tachycardias and all come into play. Yet you have a very easy way to get it into the airways to work immediately, so you have the relief. So maybe that might be my response to that question.
So we have a direct route. Let's use it. So we have another interesting question regarding management still. When do you decide to admit an asthma patient to ICU? And is it advisable to intubate an asthmatic child who is in respiratory distress but has a fairly good GCS?
Thank you for that question. I think when I was going through this slide, I explained, remember you're having the dynamics in the airways are so variable. That airway and this airway, they're doing different things. It's dynamic. And that's one of the most difficult children to mechanically ventilate. That's invasively ventilate, intubate and ventilate. Of course, children who are exhausted and their GCS, as I've mentioned, they are life-threatening. They may be at that very end where they're so critical that might be the way. But actually, in most of our practice, you'll see children who are in the HDU, in the ICU, do so well on non-invasive ventilation. And these are the benefits of non-invasive ventilation. As long as the patient is conscious, they're able to, and they're breathing spontaneously, then non-invasive ventilation is going to be your best route. Bi-level positive airway pressure is excellent. We've been using it in many of our intensive care unit, pediatric PICUs in Nairobi, and children do so well when you initiate it early. You've given your magnesium sulfate, you may need to repeat that again, maybe start your aminophylline, give, maybe depending on how the patient is. In the HDU setting, it's really how the child is responding and how you're managing and how they respond as you're reassessing continuously. Children whom you start BiPAP early really do well. They have shorter ICU stay, and you actually prevent them from going into invasive ventilation. And this is not surprising. So this is, for me, the way I practice, and it's evidence-based. So and also, so BiPAP, I've talked about BiPAP, but also non-invasive ventilation. I've talked about also earlier on when we had this slide on high flow nasal cannula oxygen. So that, like using the airway. So you're maybe at around 30 liters per minute of flow. That's really good. Again, it helps. It's a form of a non-invasive ventilation. It's not giving particular PEEPs. Of course, you can also do CPAP. But that, I think for me, BiPAP is really good because you can control how much pressure is going in and out, and it's really comfortable to the patients. You titrate to the patient's comfort. You can avert invasive ventilation, which is very challenging because of the dynamic aspects of the airway obstruction in these children. Thank you.
So while we're still in the management in ICU, would you like to say anything about the role of adrenaline in management of these patients with asthma, severe life-threatening asthma?
I have no experience with the use of adrenaline. ICU, and even in the literature, I can't see much evidence in terms of the use of adrenaline. I talked about magnesium sulfate intravenously. I've talked about medications like your aminophylline. I know, depending on where you trained, this was I think here in Kenya, it's very easy to get, and maybe where I trained before, your first route was IV salbutamol. But I think coming back home, I really love aminophylline in an ICU setting, and your magnesium sulfate and your salbutamol. So this really, really make a huge difference. You hardly need to pulse. There's evidence, there's literature supporting, when you're put to that corner, you may need higher doses of your steroids. But I think with these 3 standard medications, most children can do well, very well, and get out of your ICU well.
Okay. We have another interesting question about the role of vitamin D3 in asthma management, especially those with difficult to control. Any comments?
Yeah, so vitamin D, if you just go on PubMed right now and do vitamin D and you search it with everything, oncology, asthma, pneumonia, I mean, there's a lot of literature out there about vitamin D. In terms of what the level of evidence, so you need to ask yourself, is it for prevention? Are you using it in terms of, is it preventing the exacerbations? Is it preventing, is it part of your control regimen? So I know a number of people may be using it. I don't have how would I say, say there's guidance to say that it is harmful, but I'm not sure about the level of evidence to its benefit. So you may see some articles talking about, it's beneficial and it's useful. Some do, some don't. So I wouldn't fault anyone who's on vitamin D. It's an important vitamin, everything, but I wouldn't say that is going to be your standard treatment. Remember, when it comes to children, so you can see this is in terms of exacerbations. The slide I'm projecting here is about acute exacerbations, but sometimes asthma can be described as severe or difficult to treat asthma. These are the terminologies that are used for those children whom you're already, like, you're at step 5, you're not getting headway, you may be on daily corticosteroids, oral corticosteroids, very difficult to treat children. That's a different, very different ball game. And that's, I would say, is at the level of a subspecialist. And as I said earlier on, we all cook our chapatis so differently. So these are the little flavors that may be different, all of us may have, and may not be the guidance, I would say, that is to the general audience who is taking care of children who have asthma. So at the subspecialist level, then, there you're playing with like little things, and you have a reason why you're tweaking it this way or that way. But in terms of every child is going to be on vitamin D and that's going to be your panacea for asthma, then I think that's not a right notion. But most of us are vitamin D deficient, so you need that vitamin D somehow, and it'll help you in many other aspects of your life. So I don't know if my point has come out clearly.
Yeah, no, I think just in general, if I might summarize, is that there is no specific indication, but given that people might be deficient, you can supplement as necessary.
Thank
you. There's a question on using the inhalers alone without any oral treatment for asthmatic patients. Maybe we can take that in addition to, is it safe to use steroid-based inhalers in children less than 1 year?
So when you say inhaled medication alone, you mean an inhaled steroid alone? Yeah,
I'm not sure what the participant means, but I think that's what they mean.
Yeah, I mean, if you're in step 1, step 2, there's no harm in, because remember we said the hallmark of this disease is chronic airway inflammation. Therefore, the steroid is your everyday use. But of course, in times of exacerbation, so if children are coughing persistently, if they're wheezing or they have a tight chest, then a short-acting beta agonist could be used for that relief. But I did share with you another school of thought where you can actually use an inhaled corticosteroid combined with a LABA, even for relief. But that's the one that is combined with a LABA. So that can be used as daily medication and even in terms of for relief medication. So there's been a lot of work around that. I think for me, I'm of the older school of thought. I find that the short-acting beta agonist really works for relief very well. Yeah. But the principle is that the child should be on a daily inhaled corticosteroid. The problem was just using SABAs alone. That is what was associated with a lot of mortality and what changed our ways of that guidance not being very clear. There is no role for short-acting beta agonists only in the treatment.
So if anybody was to have one inhaler, they should have the corticosteroid one, the inhaled corticosteroid, and then the SABA would be, now we cannot have that alone.
Yeah, that one is for only during exacerbations for relief.
Okay. There's an interesting question on the effect of exercise. Please comment on the effect of exercise and lung capacity, I think in the context of asthma.
So maybe I don't know if I've understood the question well. So exercise, and I talked about exercise in children can be their play. That can be a trigger. It can exacerbate it's one of the things that gives you the symptoms. You can see that when children run up and down, they may cough more. However, I think maybe the person who's asking is asking whether, I don't know if they're asking whether we should not exercise. Children, when they're on control and they're well controlled, they should be able to do everything and anything. They should be able to swim. There are children whom I know who are in the swim teams and they're doing so well because they're well controlled. They should be able to do all the activities they wish to do or are happy to do. And that should not be limited because of a diagnosis of asthma. I don't know if I've answered their question. I can look at it as exercise, yes, can be a trigger, but if you're well controlled, then this should not be a limitation. Children should be able to live their fullest lives.
Okay, so I think we'll just take a couple of more questions and then we can conclude. Just a question on which is more effective, avoiding the allergens or using the medication?
I'll say both, but you must use your controller. You must use your controller, and then obviously avoid what is the allergen that you're sensitized. Maybe I'm seeing the person who has the dog who was their pet, and that's their lifetime. It's tricky. So and you're choosing, should this pet go and all. And you're strongly sensitized to that dog. And I mean, every time you're there, you're just coughing and coughing away. I mean, those are that balance. Of course, you'll be on your inhaled corticosteroid, plus or minus whatever the lab, and maybe the dog needs to go.
Maybe the dog does need to go. Okay, so we do have a question. Perhaps you can just type it into the chat. Some people would like direction to where you're located in case of referrals. So I think Dr. Dana will just put that for you all in the chat. And unless Dr. Dana would like to give us a parting shot.
No, I think I've really tried to emphasize the key points here. And maybe let me try and get to that so that it's like the last slide in case anyone who's going to be watching this from maybe one of the biggest take homes are, inhaled corticosteroids are the mainstay of asthma treatment. And we said that asthma is a clinical diagnosis. And then just know when to refer. Timely referral is key. And I really thank you, Dr. Tanya, for just the way you've managed to moderate the questions and group these questions in a very thoughtful way. And for KNH as a platform, and for everyone who listened to us, joined us this afternoon when we have very busy schedules to listen about asthma. And I'm going to post my email address and you can feel free to get in touch with me anytime. I'm available. Thank you.
Okay. Thank you so much, Dr. Dana, for that presentation. It was really concise. And I think all the listeners have gotten that everybody needs to be on an inhaled corticosteroid, that giving a patient the short-acting the reliever medications, that is associated with mortality, so that practice should stop. And nobody should be prescribing Ventolin syrup anymore. If you have a direct route, let's use it. So thank you so much for attending. We look forward to seeing you in the next webinar. Thank you so much. Have a good afternoon.